discharge from stabilization care to the outpatient therapeutic program, and other linkages. Here we'll discuss what happens when our patient management has progressed to the point where we are ready to send the patient home. We briefly recap on the components of Imam and then begin discussing the protocol from when the patient reaches the discharge criteria from stabilization care. When we review the 4 components of the Imam program, they are linked to ensure continuity of care in addition to ensuring coverage of treatment of patients in hospital and at home. The management of acute malnutrition begins with the component community mobilization and participation, in which early screening and active case finding within communities is conducted. These cases are then referred to the nearest health facility where the patient is then enrolled into one of the 3 treatment components depending on their nutrition status, that is, stabilization care, outpatient therapeutic program, and the supplementary feeding program. These treatment components are designed as a two-way street. This means that a patient can move upstream or downstream along the chain of treatment. For example, if a patient is admitted in stabilization care, as they recover, they are moved upstream to the outpatient therapeutic program. If they recover in the outpatient therapeutic program, they are referred to the supplementary feeding program and considered fully cured when they leave the supplementary feeding program. The opposite applies if the patient is deteriorating. They are moved downstream from the supplementary feeding program to the outpatient treatment program to stabilization care. In stabilization care, our patient is considered ready for discharge when they meet the following criteria. In children below 6 months of age, successful lactation in the mother is reestablished. The infant achieves 20 grams of weight gain per day on breastfeeding alone for 5 days, and the infant is clinically well and alert. In all other age groups, appetite has returned. That is, the patient eats at least 75% of their allocated ready-to-use therapeutic food as observed for a period of 24 hours, and medical complications are resolved or controlled, and edema is resolving. Discharged patients should be referred immediately to outpatient therapeutic care for continued treatment and follow-up. Discharge with a 1-week supply of ready-to-use therapeutic food. Children under 6 months of age should not receive ready-to-use therapeutic food. If breastfeeding is not possible, provide replacement feeding according to national guidelines. In exceptional circumstances, mothers may make the informed decision to give their children infant formula. It is possible to replace breast milk with infant formula, but this must be done as an informed decision. Due to the risk of complications and fatality in children below 6 months, the discharge criteria is strict and must be met. Children below 6 months are discharged to home with the arrangement for regular review to monitor recovery. In all other age groups, the criteria is that appetite should have returned with a patient who is eating at least 75% of the plumpy nut ration over 24 hours, and medical complications are resolved or controlled, and edema is resolving. Patients who are older than 6 months of age are discharged from stabilization care by referring them to an outpatient therapeutic program. They are given 1-week supply of plumpy nut and are referred to the nearest health facility for resupply and monitoring. In the case of central hospitals, patients discharged from stabilization care are initially referred to that hospital's outpatient therapeutic program, from where they will then be referred to their nearest health facility. This is to ensure improved care, monitoring, and evaluation. Discharging a patient from stabilization care is a process. We are aiming to promote recovery and minimize the risk of relapse. The discharge process will involve the patient, the caregiver, and linkages with other supporting programs such as social welfare. The caregiver must be prepared for discharge by trained health professionals. They should receive health and nutrition counseling, a check on immunizations, advice on family planning, HIV testing and counseling, counseling for water, hygiene and sanitation, and where available, counseling on income generation and resource allocation. During this preparation, you should establish if the caregiver is willing and able to look after the child, and if they're able to select and prepare nutritious foods for the patient. They should also understand play therapy and should be able to deliver home treatment for diarrhea, fever, respiratory infections, and they should be able to recognize danger signs that require medical assistance. On discharge to OTP, take height, weight, and MUAC measurements and use this information to complete the ward register and discharge referral note. The note should include admission parameters, a treatment summary, and the discharge anthropometric measurements. Provide 1 week supply of Plumpynut and inform the patient of any follow-up review dates. Discuss key messages on health, nutrition, and the correct use of Plumpynut. Dispense important medications and advise on how they should be used, then refer the patient to the nearest outpatient therapeutic program. The patient and caregiver are now ready for discharge to an outpatient therapeutic program. The outpatient therapeutic program provides medical treatment for uncomplicated severe acute malnutrition at decentralized sites within communities to ensure coverage. This program is used to manage two groups of patients. 1. Patients with uncomplicated severe acute malnutrition identified through active screening, and patients who are referred from stabilization care units for further management, as explained in the previous topic. The majority of patients with severe acute malnutrition are admitted into the outpatient treatment program. This has a number of benefits, including but not limited to prevention of overcrowding in stabilization centers, as only a select group of patients is admitted for management as inpatients. It reduces the risk of cross-contamination of disease conditions from unwell patients to other patients, and it reduces the cost of treatment for both the caregiver and the health system. As with all treatment components of IMM, there are screening criteria that must be met for admission to OTP. We start with anthropometric assessment using weight, height, and MUAC measurements to classify the type of malnutrition. Next, the patient is screened for medical complications, and this is followed by an appetite test. Poor appetite is an indicator of underlying issues which require admission. Where there is severe acute malnutrition and no medical complications and good appetite, we can classify patients as having severe acute malnutrition without complications, and thus they can be managed as outpatients in the outpatient therapeutic program. When a patient is admitted, the type of admission will be assigned to the patient for monitoring and evaluation purposes. Types of admission to the outpatient therapeutic program. New admissions. The criteria for admission can be either Z-scores, BMI, or MUAC. Relapse. An individual previously cured of severe acute malnutrition readmitted for a second episode of severe acute malnutrition without considering the duration between two episodes of severe acute malnutrition. Readmission. Return of a defaulter within 2 months of a last visit. Transfer in. The first type being internal transfer from stabilization care, and the second type, which is internal transfer from another outpatient therapeutic program. This is followed by a registration process to allow for tracking progress of both the patient and the program. For registration, you'll require current anthropometric measurements, the baby card, and a treatment summary if they're a referral from a stabilization care unit or another OTP center. The information collected here will be filled onto the following: a register which is kept at the OTP site, an OTP treatment card, which also remains at the OTP site, and the patient's treatment booklet, which the patient uses for regular health visits. Here is an outline of the registration process. Take the patient's weight and height and calculate the weight for height. Measure and record the MUAC. Calculate the target weight for discharge. Register the patient in the registration book. Do an appetite test. Check immunization status. Give routine medicines. Complete the OTP treatment card, which is also known as the OTP chart, and fill in details in the patient's admission book. Once registration is complete, medical and nutritional treatment can be effected. Because these patients are managed from home, there are some key issues that must be discussed to ensure improved outcomes. The use of ready-to-use therapeutic food should be discussed with the caregiver, emphasizing on how to give RUTF, how to open the sachet and give the child small, frequent meals. Initially, it is advised that the child feeds on RUTF only. However, if a mother is breastfeeding, this should continue. Breastfeed before giving RUTF. RUTF should not be mixed with water or other foods cooked or heated. Allow the child to finish their daily ration. Caution against RUTF reassignment, where the caregiver shares the RUTF allocation with other children in the household. Note that in cases where there is more than one child under the age of 5 within a household, it is encouraged to assess the other children for malnutrition, as it may be present. Good water, hygiene, and sanitation practices must also be discussed. You also need to discuss how the caregiver will administer antibiotics at home, and you'll also need to discuss basic hygiene such as hand washing with soap and ash before and after handling food, visiting the toilet, changing nappies, and safe food and water storage. The caregiver should be advised and reminded on signs to look out for when there's need for medical attention. Routine medicines should be provided to children below the age of 5. The provision of medicines will differ depending on the patient's age and weight. Here is a chart showing variations in the provision of medicines to patients that are referred from a stabilization care unit. Note the following. Children transferred from stabilization care should receive amoxicillin for 4 days after admission into an OTP. Test or treat for malaria. Do not give quinine to children with severe acute malnutrition. For complicated malaria, children should always be referred to stabilization care. Administer the MR vaccine for all children for whom there is no health card or booklet. Do not give parenteral antibiotics to children transferred from stabilization care. Give the first dose of broad-spectrum antibiotics under supervision and tell the mother that the treatment should continue for a total of 5 days. Routine vitamin A supplementation should be discontinued in children receiving RUTF for treatment of severe acute malnutrition and should be resumed after discharge from treatment. The product used in nutrition rehabilitation of patients in OTP is Plumpynut. Plumpynut is dispensed according to the patient's weight. Patients in OTP are issued a fortnightly ration of Plumpynut, so every 2 weeks the patient comes to collect a 2-week supply of Plumpynut as per the table displayed. The Plumpynut dosage is such that it provides the patient with 170 kilocalories of energy per kilogram per day. It contains all the nutrients including vitamins and minerals to ensure rehabilitation without the addition of other foods. Note that review and follow-up is scheduled on a weekly basis. However, Plumpynut is dispensed on a fortnightly basis. What this means is that patients have to visit the hospital or clinic every week. At every follow-up visit, the OTP treatment card and booklet must be filled in to keep track of the patient's progress and to identify any signs of deterioration. The following signs may require that the patient be transferred back into stabilization care: failure of the appetite test, an increase or the development of edema, development of refeeding diarrhea sufficient to lead to weight loss, fulfilling any of the criteria of failed to respond to treatment, such as weight loss for 2 consecutive weighings, weight loss of more than 5% of body weight at any visit, or static weight for 3 consecutive weighings. Major illness or death of the main caretaker may necessitate that a malnourished patient be referred to inpatient care. The transfer to stabilization care must be communicated to the relevant health professionals to allow for readmission and expedient investigation and management. When the patient achieves their target weight and they're able to maintain or even increase this weight for over 2 consecutive visits, they are considered ready for discharge. Before the patient is discharged, it is important to check if they've received sufficient health education, if their immunizations are up to date, and to arrange for follow-up by community health workers. If there is a supplementary feeding program available, patients who are discharged from OTP must be referred to that program to prevent a relapse and ensure full recovery. There are different outcomes that occur during treatment of acute malnutrition in OTP. These outcomes are used to clarify the type of exit from the outpatient program. Cured is used to describe the patient who recovers and maintains their weight for 2 consecutive visits. The patient reaches the criteria for discharge. Defaulters. There are confirmed defaulters and unconfirmed defaulters. A confirmed defaulter is absent during 2 consecutive visits and a home visit or message has been sent. An unconfirmed defaulter is absent during 2 consecutive visits and there is no information about the outcome. We have patients who are transferred out to a different stabilization center or to another outpatient therapeutic program. Lastly, there are outcomes of treatments where the child dies. A patient may fail to respond to treatment. We should be able to identify this and take appropriate action. This outcome is referred to as failure to respond to treatment, and the following criteria is used to diagnose such patients. Failure to gain weight in non-edematous children, and this occurs 3 weeks after admission. Weight loss since admission into the program in non-edematous children, 2 weeks after admission. Failure to start to lose edema within 2 weeks after admission. Edema is still present 3 weeks after admission. Failure of the appetite test at any visit. Weight loss of 5% of body weight in non-edematous children at any visit. Weight loss for 2 successive visits at any visit, and failure to start to gain weight satisfactorily after the loss of edema or from day 14 onwards. Patients who are flagged as failing to respond to treatment should be assessed as to the reason underlying this issue. When dealing with a failure to respond, we check management prior to admission into our OTP. Here are the considerations that need to be made. Was the malnutrition protocol applied correctly? Re-evaluate the appetite test. Assess the social circumstances of the patient and where possible visit their home. The patient is then placed under supervised feeding for 3 days. If there are no changes, they should be referred back to inpatient care where a full clinical assessment is conducted with subsequent medical management. If the issue persists, then the patient can be referred for diagnostic and specialist care.